Well, good morning and happy Monday. I would like to call to order the Joint Subcommittee on Human Services. Secretary, please call the roll.
Senators Canizaro, Dondero Loop, Stone, Titus, Wynn, Assembly Members Brown May, Dickman, Hafen, Hibbets, Howdigi, Monroe Moreno, Yeager, and Chair Mosca.
And I am here, and if you can please mark the other members present as they arrive. I would like to remind everyone to please silence their cell phones and electronic devices and remind the public that public comment will be available at the end of the meeting after the budget presentations. Today we have 7 budget presentations, and we are going to begin with the Director's Office. So Director Whitley, invite you to come up. And remember, we are going to go budget by budget, and you may go direct to the member. Don't forget to state your name for the record, and you may begin when you are ready.
Good morning, Chair and members of the committee. For the record, my name is Richard Whitley, and I serve as the Director for the Department of Health and Human Services.
And Director, if you mind putting your microphone closer, I'm sure we'll get the volume up too. Thank you so much.
All right. I'm joined today by Christina Hadwick, who is the Deputy Director for Fiscal Services in the department. We'll be presenting 2 budget accounts. On slide 2, the upper payment limit holding account and the indigent hospital care account. Both accounts serve to make supplemental payments to hospitals through Nevada Medicaid. Turning to slide 3. Budget account 3260 is for the upper payment limit program. This is a pass-through account associated with private hospital upper payment limit. Turning to slide 4, shows the total projected amount of the contracts and the amount projected to be reverted to general fund and the Fund for Healthy Nevada. And that concludes my presentation for budget account 3260. Happy to answer any questions.
Thank you, Director. That was so quick. We appreciate you. I do not believe we have any on 3260, but I'll see any questions from our members. Okay, thank you. You may go on to the next one. Thank you.
Again, for the record, Richard Whitley. So moving on to slide 5, the second budget account is 3244, the Indigent Hospital Care Program. This budget account was established to reimburse hospitals for care provided to indigent persons. Turning to slide 6, this budget receives 2 primary funding sources, the ad valorem tax and the unmet free care obligation. Turning to slide 7, use of these funds are determined by the Board of Trustees. There are 4 allowable uses. 1, a small amount to Nevada Association of Counties to oversee the account and administer the claims. 2, the traditional accident fund payment. And 3, the offset county match, and then 4, transfer to Medicaid to be used for supplemental payments. There are no major changes to this account, and that concludes the presentation for this budget account.
Thank you so much. I did not see any questions here, but I'll just make sure. Members, any questions for Director Whitley? Well, thank you. Short and sweet. And we will go to Administrator Weeks. Thank you so much.
Good morning, Madam Chair. Stacy Weeks for the record, Division of Healthcare Financing and Policy. I have with me here today Jennifer Krupp, our fiscal deputy, and Lynette Aaron, our chief over our budget. I'm going to go ahead and just dive in and stop at the end of every account, so that way, in case members have questions as we go. Oh, sorry, I didn't start the slideshow. All right, there we go. I think that's working okay. Whoops. All right, real quick, we're going to dive in today. I just want to do a quick recap of Medicaid financing, because some of these accounts are a little confusing if you don't know which portion of our budget we're talking about today. So I wanted to talk about that real quick, and then dive into each of the accounts individually. Sorry, it's a little touchy. There we go. So as you guys know, we have a state and federally funded program regardless of the cost. In Nevada, the federal share is generally about 60%, and our state share is 40%. That green pie there is our federal funds for the next biennium that the governor's recommending, which is about 58% federally funded at $10.8 billion. Again, that's over the biennium. Of that green pie, a little over 10% is what we consider our expansion adult population, which is where we get the 90% federal funds. It's about 1 in 3 Nevadans. Then the piece that we're going to talk about today, last time we talked a little bit about that blue piece of the pie, which was more of our general fund. Today we're going to be talking about that white piece of the pie, which is the other. This is our local or county funds, provider taxes, public university funds, our rebates, other sources of revenue that help fund our program. The green highlighted pieces here are the accounts we'll walk through today. 3157 is our IGT program, which is intergovernmental transfer. It supports a lot of our supplemental payment programs to our hospitals. 3160 and 3177 are our provider tax programs that help supplement payments. And 3245 is our drug rebate program. Before we dive into those, we did get a request to walk through some new amendments in 3243 with members. These are amendments that are different from last time when I sat in front of you. You may recall last time there was something left out of our budget. It was the MCO inflation piece, which was worth about $66 million in state general fund that we did not account for. So we have worked with our variety of folks on our team to come up with a couple options for members to consider to help offset the $66 million. The first one has to do with the Paris data matching, which is a source of data that we're required to use under federal law to ensure that individuals who are enrolled in our program are living in our state and are not getting benefits in other states. We currently use the Paris match through DWIS, our sister division, who does eligibility, but right now it's not an automated process. You may recall the LCB Auditor's Office did an audit of Nevada Medicaid a couple years ago and found that, there's a significant amount of money here if we were able to automate it. This option will allow us to automate Paris data and will bring in about $20 million in savings and reduce capitation payments for individuals as they leave our state. The second amendment we're bringing forward is to look at paying our July payment early. We do have a surplus in our account for state fiscal year 2025. If we pay our MCO payment earlier in June instead of July, it will help us offset some of those costs in the next biennium. And that's worth about $41 million in state general fund over the biennium. The third item that we're recommending is to update our caseload to account for lower expenditures in our budget account 3243 due to projected lower enrollment in our caseload. This is around some of the recent efforts around federal immigration policy changes and deportation efforts that we know are affecting individuals and families who may be enrolling in our program. And this is based on a study. Last time when we saw that sorry, I'm going to back up for a second. That threw me off. So the federal government several years ago did do some things around immigration in our public assistance programs called public charge. And the last time we saw immigrants come off our rolls in Medicaid, it was about 30% nationwide. We are accounting here that over the biennium, we expect that 15% of the individuals that we thought would be enrolled by the end of the biennium in the immigrant population will likely not be enrolled. And this is just reducing that down or related to these different policies. And we know that there will be some fear around enrolling in public assistance programs. The last item here is we're recommending to update our managed care savings statewide procurement budget amendment we offered last time, just to reflect updated actuarial analysis, and also that really looked at the unpredictability of post-COVID data in our program for budget account 3243. And this one would save it would be, instead of saving about 40 million, it would be 10 million in the upcoming biennium. So to make it easy on everyone, we put it in at a nice table on this side. So if you look at this slide at the top, you'll see the 66 million that we needed to come up with. You'll see that in the first row is the updated amounts for the budget amendment around statewide managed care. The second one is the caseload adjustment to adjust for the different enrollment patterns in the immigrant population, including lawful residents in our program. And then the Paris data matching, as you can see there, we're now going to be doing that through our vendor starting July 1. And then the early capitation payment option, which is worth 41 million. So as you can see on the bottom, the total impact on general fund savings in state fiscal year 26 is about 38 million in the positive, and then 5 million in 27, and for a total of 44 million left over. All right, I'll stop there for questions because I know that's a lot.
Yes, thank you so much. Thank you for the chart, and we do have questions, so we'll start with Senator Dondero-Loop.
Thank you very much, and good morning. Thank you very much for this information. We appreciate it. So can you discuss the updated statewide managed care analysis and confirm those figures that were reviewed and determined reasonable by the contracted actuary?
Madam Chair, Stacy Weeks for the record. Yes, originally we were hoping for over 40 million in savings with the biennium, but the hired actuary who has looked at several other states that after COVID recommended that we ratchet that savings down significantly and assume only 10 million because some of the differences when we look at post-COVID data with individuals coming off our program, the program has changed significantly. And like I said last time, we still don't really have a full set of 6 months of data. So they're recommending, or the actuary that we hired recommended 10 million for the biennium.
Okay, will that work?
Madam Chair, Stacy Weeks for the record. She felt like it was very conservative. We do believe we will see some savings from statewide managed care. I do think it's fair that it would be mostly in the second year, not the first year. And then ongoing, she thinks those savings will grow. But she is a licensed actuary and used to work for Milliman and is now consulting with us on the side.
Thank you very much, and thank you, Madam Chair.
Thank you. Majority Leader Hadigi.
Thank you, Chair. And just a couple of questions for me. From the material that we received, I know that we had identified about 50,000 people who were enrolled in Medicaid programs in 2 different states, and the agency indicated that the assumption is 25% of these people don't live in Nevada. Can you walk me through how you guys got to that 25% assumption number instead of like all of them or 50% of them? How did you guys assume, get to that 25% don't live here, but the other 75% do?
Madam Chair, Stacy Weeks for the record. Our consultant looked at our own data and patterns of how quickly we're able to disenroll people. They also looked at the LCB audit findings that came before this legislature.
Okay, can I follow up? Do they track addresses in other states as well for those people, and like when the most recent claim was?
Madam Chair, Stacy Weeks for the record. I don't know the nuances. All I know is it's a Paris data match that federal government requires us to use. And if someone's enrolled in another program, it identifies the other state that they're enrolled with. So the two talk together. And so this just allows us to actually move quickly on that notice from the other state in the Paris data matching system.
And then just one last question, Ms. Weeks. Can you talk to us about the timeline for rolling out that automated Paris verification process?
Madam Chair, Stacy Weeks for the record. We currently have a contract already with the vendor who's able to do this. They're offering to do it with just a contingency fee starting July 1 of this year.
Thank you. Next, we'll go to Assemblymember Brown May.
Thank you, Chair. Thanks for the presentation. It's great to see you, and thank you for following through on the what we've seen as the trend with the Nevada Legislature being the vacation week expected spot for our youth and children. So it's really great to see your family here with us as well. Thank you for that. My question is really about this one-time recommended utilization of the general fund surplus. I wonder if maybe GFO could talk to this as well, Chair, if you're interested, right? So it looks like there's a recommended utilization of one-time general funds to fill the surplus for ongoing operational expenditures over the biennium, as opposed to reverting the funds. I'm curious to know why we're using a one-time to work on recurring expenses.
Madam Chair, Stacy Weeks for the record. It's an option before you. Either you take it or not. It's an option we've used before to try to make sure when we've had extra funding or we need to maximize federal share in our program before the next state fiscal year at the federal level. This is one option so we know we have the surplus right now, and it's a way for us to help fund it. We also are offering additional funding in front of you. As you can see on that original slide, 44 million left over. There's more than enough. So if you decide to not direct us to do that, we don't have to. But I can say at the end of the bottom line, there's a little over 20 million in reversions left. And if GFO wants to come up and speak to the exact amount, but it's about 21 million.
Yes, if the GFO would like to come on.
Good morning, Madam Chair, committee members. Tiffany Greenmeyer for the record. Yes, it's about $21 million that Medicaid is going to revert at the end of the day after a known audit that's going to be paid this year, and reducing, paying the capitation payment in fiscal year 2025. And then we'll have one less payment in fiscal year 2026.
Thank you. My question really is, why are we using, what's the thought process behind using excess money as a one-time appropriation as opposed to building the budget for recurring payments? As you know, it's not our intention to encumber the next legislative body. So really, as we're working to build our budgets out for the biennium, I'm curious to know why this methodology was used.
As you know, there was a $66 million Tiffany Greenmeyer for the record, $66 million missing for inflation. At the time, it was considered that, this would be an option as to using the capitation payment, the extra payment, to try to help shore up this $66 million hole that was discovered. But since then, we've had other budget amendments that have been sent over because of other errors that have occurred. So we can take this option. We can either take the option or we don't have to take the option. And we would still have the fund balance would still be at above the 5% and still stay in balance for the structural balance. So,
thank you.
I hope that helps.
I appreciate that. Thank you. The only concern that I have when I look at the numbers is that it appears as though we'll start the next budget cycle with a $41.5 million hole that already exists that we then have to fill. So I appreciate your comments. Thank you. Thank you, Chair.
Tiffany Greenmeyer for the record. Also, in the next coming up 28-29 budget, we'll have probably more savings that we assume than from the capitation payments. So not necessarily that hole will be there.
Thank you. Next, Assemblymember Monroe Moreno.
Thank you, Chair. And my questions are on the caseload changes that's based on the federal immigration policy impact. Is this a new provision, right? And there's an assumption that a number of families may not reapply for their their benefits, but could you discuss with us what the analysis or the data was used that informed this 15% figure that is estimated to be the impact with this immigration policy changes to our Medicaid caseload?
Chair, committee member Stacy Weeks for the record. Yes, I can. So last time when I think it was the last Trump administration did public charge, there were a lot of studies around fear around immigrants coming onto public assistance programs, especially when they're looking for unlawful immigrants. Kaiser Family Foundation had a study that it was a little over 30%. I want to say it's 30, as much as 35%, actually did not come onto the rolls or disenrolled for that population. This included people who are lawfully here because they may have a mixed household with an immigrant in the household with them. So we, to be conservative, the Office of Analytics looked at 15%, so half of that, which occurs over the 2-year period. So by the end of the next biennium, they're just assuming that about 15% of individuals will likely no longer be enrolled in Medicaid that are in that immigrant population. But we're more than happy to share that study if you'd like to see it afterwards.
That would be great, Chair, if we could get that study, and thank you so much for the answer.
Yes, thank you. The committee would love to see that. Any other questions on this budget item? Okay, thank you so much. We can go to the next one.
Thank you. All right, Chair, Committee Member Stacy Weeks for the record. So we'll move to 3245, which is our rebate account. Let me pull this up real quick. Our rebate account is where we collect our drug rebates in the program for Medicaid. This account collects all the rebates, also from managed care and fee-for-service, into one account. It's also federal and supplemental rebates. Supplemental are MCO rebates. They include, when you look at the funds, they include federal and general fund components of the rebates. So when we get a rebate dollar, we have to send back about 70 cents of that dollar. They're around 30% we are keeping in the next biennium. The federal share is returned, and then and we also take some of that funding to offset different expenses in our 3158, which is our administrative account, but mostly our medical expense account. If these funds are not spent, they do fall to the general fund. All right. Okay, so let's move to the E252 on slide 11 here. I'm sorry if you have an extra slide in your deck we're missing. Oh, so this is I have a lot of visuals that are not on here. So this is a different deck. Okay, sorry. So this slide was supposed to have a visual for you to see that when we collect the funds, how the funds work in the accounts and how they are moved across different accounts, and the federal funds are returned back to the feds.
And we do have that visual. Just
Oh,
so
you
know.
do?
Yes.
Okay, good. Okay. E252 is the single preferred drug list. So the governor's budget is recommending that Medicaid implement a single preferred drug list for outpatient drugs across Medicaid managed care and fee-for-service. This will streamline the program for medications and prescriptions for recipients, regardless of what plan you're in, and it will also simplify the process for our providers and pharmacies. This request is associated with a budget amendment to make sure that these funds are captured appropriately in the accounts. Originally, they were not. As you can see, we are estimating that we assume about $25 million over the biennium will be saved, or be new revenue that we're able to generate with single PDL in terms of rebates. Again, 33% of that is the state share. E262 is an enhancement requesting a transfer of around $10 million. Right now, it shows that this is $10 million for each year that will go into enhanced reimbursement through Medicaid to sites that do graduate medical education and other workforce and training with our universities and partners to improve access to Medicaid recipients. There is a budget amendment that we discussed before that would make this only effective in year 2 would be the 10 million that would be capturing. So in the budget amendment, you would see 0 for state fiscal year 26. Next slide, E269 funds an increase in projected drug rebate revenue. This request funds an increase of about 13.27% that we are seeing from the base budget year. E281 is funds, this is part of the Nevada Health Authority. This is funding to support a new healthcare purchasing strategy. We'll be working to model with a variety of actuaries and experts nationally, different healthcare purchasing strategies with PEB and the exchange as well as Medicaid to present those to lawmakers as well as the various boards associated with those programs. E301 is our modernizing Medicaid enrollment. This is what we call our Medicaid Express. This is funding to support a new automated enrollment system through the exchange. This would allow us to have our managed care recipients be able to shop for their plans, pick a plan, compare their networks, and also determine whether or not they're eligible as they maybe get more income and they come out of Medicaid, whether or not they can pick another plan or the same plan when they're leaving. This allows for more streamlined and automated enrollment. E303 requests to transfer to fund staff professional growth and development. As you guys know, Medicaid is very complex and complicated, and one of the things we'd like to do is really have a professional growth opportunities at our division, including a Medicaid Academy, where we're able to train our staff and really support a pipeline to leadership, as well as to fund additional training to go to a variety of national conferences to learn what other states are doing. This also includes a new training officer for our division to help support these efforts. There are a couple adjustments I wanted to mention to all of you today before we dive into questions. The general fund impacts were not included in the decision units. So like I mentioned, the 33% of a total amount was not included and reflected. So we're requesting that we can work with LCB to adjust a variety of these enhancements to ensure that those general fund amounts are accounted for, and also adjust the effective dates of a variety of these programs, not only because we want to ensure that we're only using the single PDL savings that we mentioned earlier, but also because we recognize that the federal timelines and the transition to Nevada Health Authority will take us some time. So with these adjustments, the division is proposing to spend only the new revenues that we're going to generate with single PDL from that implementation for these enhancements. So in state fiscal year 2026, just so you have a sense of that 25 million, the state share of that single PDL revenue that we estimate that we're going to generate is about 4 million. And in state fiscal year 2027, it's about 8.2 million. And again, like I mentioned, we are just proposing that we spend that funding, that is recognized here in the budget on these enhancements. So on this slide here, slide 15, is just the state general fund impact of the single PDL and these programs. At the top is the amount that we estimate that we would save. Each of these items with several adjustments, including delaying hiring of certain staff, and a delay of 6 months on E301, the Medicaid Express, to align with contracts, comes out that we would still have some of the savings left over, so about $818,000 in year 1 and $332,000 in year 2. So we would not be spending the entire bucket. It's about $1.2 million left over at the end of the biennium. And I will stand for questions.
Thank you so much for that very helpful information. We have some questions, so we'll start with Majority Leader Hattie.
Thank you, Chair, and thank you again, Ms. Weeks, for this presentation. I have questions on E269, that decision unit. I know during the 23 legislative session, we issued a letter of intent, and the agency responded with the recommendations, and it was just directing the agency to evaluate prescription drug projection methodologies, and the agency responded with 4 different methodologies that could be used. And just from the material that we received, it looks like just a single factor was considered. And so can you just walk the committee through why all 4 methodologies weren't used?
Thank you, Jennifer Krupp, for the record. Division of Healthcare Financing and Policy has considered like each of the four methodologies, and
Ms. Krupp, if you don't mind just going a little closer to the microphone, thank you.
I am so sorry. I tend to be a little bit short. As the division had discussed, and again, Jennifer Krupp for the record, we continue monitoring each of these projection methodologies, adapting, as we had indicated, the drug rebate landscape and determining the most appropriate way forward. We are still carefully considering like the best way to move forward with prescription drug monitoring and projecting out these rebate methodologies. One of the biggest concerns is the complexity of monitoring drug rebate methodologies. We do have the federal rebates that we monitor, as well as through our contracted rebate vendor, which is Prime Therapeutics, formerly Magellan. They do have individual rebate contracts with each of the pharmaceutical manufacturers. And so depending on a combination of utilization and prescription drug expenditures, we can have differences in our projections that are challenging to monitor due to some of the, protected contractual information that our rebate vendor Prime has with the individual drug rebate methodologies. We are included in a rebate pool with other states under our Prime contract. So let me take a deep breath. I don't want to confuse you, but there are a lot of factors that can go into the drug rebate methodology projections, and it does require a lot of real-time monitoring of prescription drug utilization and expenditure, and then truing that up with the actual rebate agreements and contracts, either with the federal government or through our rebate vendor. So it can make it challenging, which is why we are continuing to monitor the four different methodologies that were outlined in the letter. Is that clear?
It is. I know it's a very complex issue, and so I guess and this might help too. I mean, given it's so complex, and why was it that the agency decided to base the prescription drug rebate revenue on total prescription drug spending? Can you walk us through that?
Madam Chair, Stacey Weeks for the record. I'd like to call up our state pharmacist on this item. Thank you.
Chair, committee members, Dr. Duncan for the record. I just want to make sure I captured the question. Your question was, why did we base the drug projection methodology on total prescription spend?
Thank you, Madam Chair, and I'll restate it. Yeah, I know it's a complex issue, and thank you for walking us through it. But based on that, like there was four methodologies recommended, and then the agency decided to go with rebate revenue on total prescription drug spending. So talk to us about how you guys decided that was the best method.
Chair, committee members, Dr. Duncan for the record. Yes, so the total prescription drug spend would be essentially the best reflection of all four of those methodologies. So essentially, part of that has to do with drug inflation, right? So where we see drug prescription spend year over year, how we see that increase, decrease, or change in particular classes, right? So that's going to be reflected in the previous year's total prescription drug spend. Where we see the difference between essentially the drug pipeline. So where we see new prescription drugs being created, the cost of those drugs between each year, between each year. So that would reflect essentially the total brand generic market. So brand drugs will be the first drugs that come out. So that would be, it essentially reflects all of the above is what I'm trying to say. So you see the drug inflation year over year, you see new drugs come out year over year. You are then able to reflect on previous rebate methodologies of past years. So using that total prescription drug rebate would be the best reflection. I don't know if that helps. I can clarify further if you need.
Okay, thank you. I appreciate that. Yes. So next we will go to Chair Wynn.
Thank you. Oh, you could probably stay here. You might have answers to these questions too. A little bit more about how that implementation of that single preferred drug list would impact all medications for Medicaid participants. I know that we are trying to do something new here, so I'm just wondering how that shift in that market share from the utilization of brand name medications over to generics might result in some of the changes. If you could just kind of discuss some of that, one of you.
Chair, committee members, Dr. Duncan for the record. So I would want to clarify, so it's not just shifts from brand names to generics, it's shifts from generics to brands as well. It's a better reflection on, like I mentioned, some of those new medications that come out, as the year progresses. So essentially, what it maybe might help to describe a little bit of the current landscape as well. So we currently have 4 managed care organizations as well as fee-for-service, which means we have 5 individual preferred drug lists. So essentially unifying all of that over to a single preferred drug list. Helps us sort of expand the access for our recipients, as well as streamline that process. So instead of our recipients, our prescribers having to follow 5 different instruction sets, essentially, they're able to just follow one. And we're able to kind of clinically optimize each of those particular drug classes that is both best for our recipients, it's best for state drug spend as well, and of course for the administrative burden on both the provider side and our side. So it's a mix of a lot of things, once again, but essentially with the keeping in our mind's eye ensuring that we have an appropriate access for our recipients and what's clinically optimal.
Thank you.
Thank you. Next, we have Senator Don Loop.
Thank you very much, and thank you for that information. Can you talk to us a little bit about the analysis that was conducted to quantify increased gross prescription drug costs the agency indicated may result from the implementation of that single preferred drug list?
Madam Chair, Stacey Weeks for the record. We had Mercer work with Prime, our vendor that does our rebates, and they came up with an analysis that showed we probably would actually be saving or bringing in more rebates, about $20 million a quarter. To be conservative, we are only recognizing here in front of you a third of that, and with that $25 million. So we're planning to monitor it very closely to see if actually it does come in to be that $20 million, but we didn't want to overshoot on that analysis.
Thank you. And so what feedback related to that proposal to implement that single preferred drug list has been obtained from the managed care organizations and Medicaid participants?
Madam Chair, Stacey Weeks for the record. We did do a couple public workshops while we were designing the statewide managed care contract and procurement. This was discussed. We did have favorable feedback from several pharmacies as well as recipients. Managed care plans, obviously, I think like having their own single PDL, but they are willing partners and are not opposing it as far as we are aware.
Thank you. And one more question, Madam Chair. So can you also explain why the agency anticipates that $12.5 million in 26 and $25 million in fiscal year 27 in additional rebate revenue from the implementation of the single preferred drug list when the contracted rebate vendor projected $20.1 million to incremental rebates each quarter, or $80.4 million annually?
Madam Chair, Stacey Weeks for the record. As I mentioned earlier, we decided instead of assuming $80 million in savings in total, that we would go with a third to be conservative and not overshoot. We'd rather come in low than high on assuming savings.
And I appreciate that. Thank you very much, and thank you for what you're doing, and thank you as well for joining us today. Thank you, Chair.
Thank you. Chair Nguyen.
I'm going to kind of go back to, sorry, where was my notes here? I guess the use of savings from the prescription drug rebates. I see you're using some of that for the graduate medical education. Is that my understanding in reading the documents that you had provided, as well as some other programming through the Nevada Health Link and some professional development?
Madam Chair, Stacey Weeks for the record, yes. We are asking for, on slide 15, we're asking for the administrative costs for the single PDL to be funded with that savings. We're also asking for about the 10 million, which would be about 3 million of that we can match with federal funds to go into new reimbursement structures to support graduate medical education. And then the Medicaid Express in the first 2 years to be supported by this savings, and the professional training and that vendor support for the new healthcare purchasing strategy, which will also look at ways to maximize pharmacy rebates across PEB and Medicaid across our programs. And I think, yeah, that's it.
So that kind of answers my question. So that's how you intend to address the return of those federal share of rebate revenues in those, I guess, 1, 2, 3, 4 enhancement decision units.
Madam Chair, Stacey Weeks for the record, that is correct.
Okay. And then kind of in line with that same idea is, and I think you might have addressed this, but I just want to clarify. I see that I guess, if there's a 33.1% actual state share of prescription drug rebates, is that why do we choose to use the 22% rate utilized in the base budget to project the state share of prescription drug rebates in the 25-27 biennium instead of that 33.1? It just seems like that's a huge swing. It's like around $45 million. So I was curious on why we're using one versus the other.
Chair, committee members, for the record, Lynette Aaron. So our base budget did use a 22%. That's what was previously set as the general fund percentage back in 2022 is when we built the budget. But we did adjust it upwards to 33% because that's more reflective of what we saw in rebates in state fiscal year 2024 in terms of the general fund portion. Currently, though, for state fiscal year 25, for example, though, we are seeing an increase in that general fund share. It's about 34.6%. A lot of it is largely attributed to the fact that the FMAP is decreasing for our state, right? So now that state share is higher. And so in that time period when we are looking at the 22% that's reflected in base, that was during the time of the COVID FMAP, so we had that 6.2% increase.
So do you anticipate that you would have to actually seek more if there's additional changes? You had mentioned that just more even recently, it's at 34%. Is this...
Chair, committee members, for the record, Lynette Aaron, I do think that 33% that we're using right now would be more conservative. I think that's I think that would be the choice that the division would like to take, is to use a 33% and rather wait till we see what the full year of state fiscal year 25 looks like in terms of that percentage growth.
Thank you. Thank you, Chair.
Thank you so much. Any other questions on this item? Thank you for answering all our questions, and we will go to 3157.
Thank you, Madam Chair. Stacey Weeks for the record. So 3157 is our account that collects non-state government transfers from counties and other public entities to help fund the state share of our program. It includes supplemental payments to hospitals, also supplemental payments to graduate medical education sites. Again, the state share is paid for by the locality or the university, the academic center, and the regional transportation commissions, as well as a new academic partnership program that we're going to mention here today. So in First enhancement that we're requesting is E253, and this is, we talked about this last time. This is eliminating the county funding requirement for school health services program. Right now, we do not mandate that all counties pay for this, and therefore have put us out of compliance with federal law for statewide-ness. So to ensure that we continue this program and do not have any compliance issues, we are recommending that the state pick up the share of that program. This is just reflects what the savings to this account in doing so. E255 is the increased supplemental payments for the various programs. As you can see, these programs are growing. That includes our DISH program as well, and supplemental payments to our hospitals, as well as some of our academic supplemental payments, about $55 million each year, and requested transfer. E309 includes a new Medicaid academic partnership. Many states work closely with their public universities and do what's called a Medicaid academic partnership, where the division would actually draw down federal funds and the academic entity would pay the state share to help support Medicaid. Some of the things that we're looking at is with right now, we've been speaking with UNR, but we're also talking to UNLV about opportunities in the future, but looking at ways to provide research, clinical expertise, and academic support to Medicaid in support of advancing our priorities. This includes several faculty and clinician positions that we will be helping draw down federal funds, and 75% of their time will be spent on supporting efforts that will improve access and outcomes for Medicaid. So we're very excited about this effort because it allows us to bring in some of that clinical expertise that often we have a hard time hiring and maintaining internally, and it gives us a variety of expertise and tools at our hand and our fingertips that we don't have today. And I think that's it for that account. I'll stand for questions.
Thank you. And we will start with Majority Leader Headege.
Thank you, Madam Chair, and I promise this is the last time you have to hear from me, I think. I know. But I'm actually really excited. I want to talk about E309 Decision Unit. I think that's great, the academic partnerships with our medical colleges. And so I just wanted to see if you could give us a little bit more information, what that academic partnership's going to look like, and how I'm assuming that's going to turn into improved customer service for patients. Thank you.
Madam Chair, Stacey Weeks for the record. Thank you for that question. Right now, we are looking at drawing down funds to support a new clinic faculty position for geriatric medicine, who will also provide services to Medicaid recipients in one of their clinics, but also supporting our works around seniors, as well as advising other divisions in the department. We're very excited about that position because geriatrics, as you guys know, is very important, but also a field that we lack very many experts in, and it'd be very hard for us to hire that in-house. So to have that individual be able to, we can access directly is huge for the state and for Medicaid and for all of our programs. The second one is really child and adolescent psychiatry. There's going to be a position hired to support those needs and really working on our children's behavioral health work, giving us clinical best practices, standards, all the things that we hear we don't have, and really helping us set up centers for excellence in the state, helping with that DOJ settlement agreement work that we're doing. Also, women's maternal health, as you guys probably know, I've said it a lot, we rank last in the country for women's and infant health. This position would be supporting and looking and doing research with us on how do we improve those outcomes in this state. So very excited about that. Hopefully it'll be an OBGYN, which we know is also rare in this state. So those, and the last but not least is a newer one that UNR came forward. We would love to do at Medicaid a population health management strategy. And to do that, we really need sort of a clinical perspective and someone who understands data. And so having someone with that clinical informatics expertise and a physician is going to be very important and helpful to doing a real population health management strategy in Medicaid. A lot of states have that we do not in Nevada. So this item, yes, I'm very excited about, and it is free to the state. So that's the good news. And we're happy to report back to the legislature on all the great things that these efforts will do. Thank you.
I think we're all equally as excited. I'm sure you are more, but this is very exciting. And so my next question was going to be how many positions would be created? So it sounds like it's going to be 4 with UNR, but you mentioned that you might create that same partnership with the UNLV School of Medicine. Would this potentially double the positions and create more access?
Madam Chair, Stacey Weeks for the record. Yes, right now there are 4 positions, but we are still talking to UNLV. I think we're trying to figure out what makes the most sense in the southern region. I will say there's also the public health school. We're looking at opportunities to do a partnership with them, maybe not paying for staff, because we do get a higher matching rate for clinicians, but for the public health management or population health management strategy, having the public health school really support that. So that's the other opportunity, and maybe building a pipeline of people who love Medicaid. So can't wait. That is actually my evil plan. But no, I am really excited about getting students involved and all the things. So thank you for those questions.
Thank you. Very exciting. And next we'll go to Senator Titus.
Thank you, Madam Chair. And Administrator Weeks, you're always a sign of hope for the department, so always enjoy hearing from you. I just need a clarification that the positions that you are hiring, although they are clinicians and they bring that clinician background, what they're accessing is help them then you develop policy. They are not seeing patients when they're working with you, correct?
Madam Chair, Stacey Weeks, the record, right. But they will be helping the university and their clinics while they're doing work. And so also learning from what it's like to support Medicaid recipients. But we will be paying for their work to help us on that 75%.
Thank you very much. That's a good partnership there, bringing somebody with some clinical background and helping them set policy. So thank you for that, and thank you, Madam Chair, for the question.
Thank you. And members, any other questions here? Okay, with that, thank you. We'll go to 3177.
Thank you, Madam Chair. Stacey Weeks for the record. So this is our account that is our private hospital tax program. Hopefully you have the pretty visual in front of you. This is a program, as you may recall, has been around for about 2 years now and for the last biennium. And what it does is it collects tax revenue from the hospitals and matches it with Medicaid federal funds, and it pays out a supplemental payment on top of the base rate that hospitals receive. So there is a net gain for most hospitals that participate in this program, but not everyone is a winner. I just want to note there are some losers, but luckily for our state, those losers aren't very large. But they come out in 2 different payments. So the first payment that we can give hospitals is on the managed care side, and those are called state-directed payments. And then on the other side of the house, we supplement their fee-for-service rates, and those are called supplemental payments, or you might have heard upper payment limit, UPL. Those are those payments. Upper payment limit payments on the fee-for-service side go up to the Medicare average, you can say, and then on the state-directed payment on the managed care side, right now, we can pay up and supplement up to the average commercial rate. For this account, the funds are transferred from this account to 3243 to support those supplemental payments and behavioral health care services. As you may recall, last session, we are allowed to collect up to 15% of that tax to fund behavioral health care services through Medicaid. And so we've been working on some of those efforts over the interim. Currently, this program serves over 40 hospitals. For this last biennium that we're almost ending, the division paid private hospitals a total of about $1.2 billion in supplemental payments and state-directed payments under this tax program. So it's been very successful. It's been a huge lift and a huge partnership with the hospitals. I just want to thank all of their hard work as well as our staff who have put a lot of time into this. Of these total payments, $488.2 million was paid for with the tax revenue, which leaves a $777 million net gain for private hospitals in this state. The division will have collected by the end of this fiscal year about $72.6 million in tax revenues to support behavioral health care services and supports through Medicaid. I just want to note that this is a very significant and important piece for our program, and I think we're one of the few states that has this dedicated funding revenue sources for children's behavioral health care. So very proud that our state has put forward this effort. Real quick, we'll dive into some of the enhancements. I did want to walk through a couple of the mandates, though, just so you have a sense of what's coming out of these funds. So the first few items I'm going to be talking about are part of that 15% of that revenue, that $72 million. So for mandate 501, we're under the new settlement agreement with the U.S. Department of Justice. As you may recall, children with behavioral health needs in our state lack actual community services, and so have no other choice often but to their families end up having to put them into an institutional setting, or they end up there in foster care in institutional settings. So this, as part of that agreement, we are required to come up with a new delivery system for care for these kids, including a specialized managed care plan, which is going to be fully integrated. So it's not going to be behavioral health care over here, or medical over here, and dental over here. It's going to be a fully integrated benefit for families to hopefully help them better navigate, and it will include all of the benefits that they are covered for in Medicaid. This portion here will be funding actuarial services to support standing up that new plan. M504 is the mandate around juvenile justice coverage. As you may recall, the Consolidated Appropriations Act of 2022 passed new coverage for youth in the juvenile justice system, and it covers them up to 30 days prior to their release. We are currently in the process of ensuring that those who want to access these services and bill Medicaid for them in the juvenile justice system are able to do that. This started actually in January. That was the federal mandate. So this is available now. We do have limited, I think, billing going on. I think people are still trying to figure out how to become a Medicaid provider, and so we're working very hard with them. But this helps fund the state's share cost of those newly required coverage for these kids. Next slide, please. E256 is our supplemental payments and behavioral health services. This is the projected increase in the tax revenue from the base budget amount in fiscal year 2025. This request also funds ongoing costs for the new behavioral health services and rate increases previously approved in April IFC. So when you look at this bucket, this is all the funding that really supports some of the things that this legislature during the interim at IFC passed for us to implement for the settlement agreement for children's behavioral health care. I'll walk through those in a little bit here in a second, but I just wanted to note that we are on track as far as we can be in implementing a lot of these services. Some of them we've had to wait till the DOJ settlement agreement was signed. Originally, we thought when we came in April that we were very close to being signed, and as I've learned, I am not good at predicting things. So we are just got that signed in December. E258 is some of the new vendor resources and rate increases that we would like to implement to strengthen our mobile crisis system. This is part of the DOJ settlement agreement, and is a very big piece of it, is that we have a statewide functioning, available mobile crisis system. We are working very hard and closely with our partners at DBPH, but what our efforts will be doing is bringing in a vendor to help us create tiered rates for the system, so that way those folks who maybe don't quite have not met that enhanced mobile crisis model that DBPH is rolling out, that we'd love for providers to meet. For example, some folks can't have 24-hour availability in some areas, so we're allowing them still to be able to bill us for the services they are providing, but at a tiered rate. So if they are able to get that enhanced best practice standard, great, we'll pay them the highest rate, but we are trying our best to get some funding out the door to those that are trying to build that infrastructure. E260 is our new bundled payment approach to assertive community treatment. Those of you may not maybe know, but this is a very intensive service that's provided to individuals that have serious, significant behavioral health challenges and diagnoses, including schizophrenia, bipolar disorder, and other psychosis. This is a treatment that is a multidisciplinary team that is built in the community. It's available 24/7, 7 days a week. So it is very intensive, but it is designed to really support individuals to help them stay in their home. And so instead of us institutionalizing them, this can be provided to younger adults, but it's also mostly an adult population. But we feel like it's a very important piece as we move forward in the spirit of DOJ to really ensure that we have community options for individuals. E266 funds improved payment method and rates for community paramedics. Currently, we have this benefit. I will say the rates are pretty low and no one's really using it or taking it up. So we do know in other states that this program has been wildly successful, especially even in the behavioral health space. In our rural areas, we feel that this would be a huge benefit, as well as even in our urban areas. So we are asking that we really invest in this program to really improve access and to ensure that community paramedicine grows statewide. E268 is our funds our case management and care coordination. I mentioned earlier that new children's specialty managed care plan. This would be funding the administrative portion of that capitation payment. So all of the benefits are currently covered and built in our base as medical services, so we do not need to fund anything there. What we do need to fund is that intensive managed care and care coordination. So this item here reflects that and would be built into the capitation payment. E271 funds a Medicaid rate increase for partial hospitalization PHP program. So currently, I just want to note that this rate has not been increased since 2006. It was bundled in 2019 to be about 4 hours a day, to be about $328 per hour, and we're asking to increase it to $500 per hour per day, but at least 4 hours a day. So there's a limit on it in terms of how many hours they can bill. E272 funds a Medicaid rate increase for day treatment services. Again, this one has not been increased since 2006. This does serve a lot of young children, 3 to 6, in a group setting. During a lot of our public workshops, we heard about this service as well as PHP, the one I just mentioned, as being an area where the state lacks significant infrastructure. And so we're asking that we increase this hourly rate from $32 to $100 an hour. And this is consistent with some of those rates in other states that we're seeing. E273 funds an increased inpatient psychiatric and detox services. In April IFC, we asked for parity at a minimum for these services. So when someone goes in for these more intensive services in an inpatient setting, that they read that the psych facilities receive the same rate as an inpatient hospital. That was at $944. And now we're asking that it be increased to $1,250. And this is consistent with a lot of the needs that we're seeing for a lot of our psych facilities when we have to do what we call temporary letters of agreement to give them a rate increase to try to get them through temporarily. This is the rate that seems to be most substantial to help them stay stable. E274 funds the Medicaid reimbursement for first episode psychosis treatment. A lot of states are adding this because, as we know, schizophrenia and some of these other significant disorders, including bipolar, are often identified early at the age of youth as well as young adulthood. And this is really developing a treatment model in Medicaid that's covered to support this support treatment to try to reduce the long-term significant impacts of these diagnoses. E275 supports a new quality add-on in payment and staff costs for the behaviorally complex care program. If you may not be familiar with this program, it is part of our skilled nursing facility program. So if a skilled nursing facility is willing to take on some of our more challenging and complex individuals that have serious behavioral health needs, we add on a payment to help support those needs. And this would actually create an additional bonus payment for any of these skilled nursing facilities that in the BCCP program that actually are meet certain quality metrics and working with their local hospitals to ensure that individuals are not stuck in the inpatient setting and they're moving out and getting into the community, including a skilled nursing facility. So this would be something we're trying to stand up in the interim. And I'll stand for questions. Thank you.
Thank you. Thank you for that great summary. And with that, we'll go to Chair Nguyen.
Oh, you can't talk about this bill or this money without having a question for me. So thank you. I'm just wondering if you can give us any kind of status update on the federal approval status regarding the operation of the private hospital provider tax program for this year, and potentially if there looks like there will be any issues going into the renewal of this program.
Madam Chair, Stacey Weeks for the record. So I do have some good news on that. Good. I mean, I think it's good. It's hopeful. So a couple weeks ago, it feels like maybe it was 2 weeks ago, our governor's office has been working really closely with individuals at the federal level and has been able to, we were one of the few states that was able to get early release of one of our quarter payments. So we were able to pay out quarter one, which is about $200 million. Hospitals should be receiving those checks April 11th. We are still waiting final approval of that entire preprint, which would be a calendar year. So once we receive the full approval, we'll be able to pay out Q2, and then Q3 and Q4. But at this time, we're just waiting. We did have some back and forth earlier last week, so they're definitely still asking more questions. I will say that they are really looking at how they define what they think is the average commercial rate and how we defend that. So that's where the rub is, it seems. We're working really hard with Mercer to address those concerns. So hopeful we'll get approval in the next few weeks for the whole calendar year. But hospitals, I hope, have some relief until then. So thank you.
That's great to hear. Do you anticipate, I mean, you kind of alluded to it, that there might be some decreases in what we're eligible for, and how right now we're building a budget and supporting some of these amazing programs that we so desperately need here, not only to be in compliance with the DOJ settlement, but also settlement order, but also just to expand some of these resources in the ways that are needed around mental health services. So I'm curious if you have some concerns about whether or not we will have the resources to support the programs that you just explained.
Madam Chair, Stacey Weeks for the record. I think with our last phone call with CMS, we do believe that we will get an approval. The amount that they'll actually let us pay out is always questionable. That's what I'm more worried about. I do not see at this time that they're not going to allow us to collect the tax. I think it's more about whether or not that we all agree on what the average commercial rate is and how much they want to allow us to get, but it should not impact the Children's Behavioral Health Care Program.
Thank you.
Thank you. Next, we have Assemblymember Brown May.
Thank you, Chair. Thank you. That's good news. Let's start there. That's really good news. Thank you. I'm wondering, can you provide an update on the implementation of the service expansions and rate increases that were approved at the April 11th meeting of the Interim Finance Committee?
Madam Chair, Stacey Weeks for the record. Yes, I can. So there were several rate increases that were approved at April IFC. Those are all still pending federal approval. All state plan amendments have been submitted, and once they're approved, we can go back retroactively to January 1. So fingers crossed things move, but you never know with CMS. Sometimes it takes us a little longer. The benefits, there were a couple new benefits that were added, like the group, more of a group home model or community model for kids that we are still working on with CMS as well as some of our partners. I will say that one of the reasons we were kind of delayed in sort of getting everything stood up, like I mentioned earlier, is that we were hoping, and I thought by June we would have the DOJ settlement agreement signed. So when we came in April, I thought, we're going to be rocking and rolling. We'll have an independent reviewer on board, and we would be able to get everything through. The reason I say that is because the DOJ settlement agreement requires that each of the new benefits that we design and all the policies around it are approved by them and our independent reviewer. So we've been sort of in a holding pattern, and then we just got our independent reviewer, went to BOE, the process. So here we are in March, after December signage, finally getting what we need. So now they are reviewing, for example, our family peer support package. And if once we get approval, we'll be moving forward on all the policies around that. We are still also working with CMS closely on which federal authorities we choose. We're trying to avoid, for example, very significant waivers, which have a lot of strings tied to them. So all of those things to say, we are in the process. Hopeful we'll get the rate increases approved soon. And then hopefully DOJ and the independent reviewer will approve what we're working on, so we can get those submitted as quickly as possible.
Thank you. And then you said that you contracted with an independent person. Is that the actuary? Are you doing an analysis related to those rate increases with an actuary? And then can you just, before you answer, if you don't mind, clarify that no general fund then would be used, right? It looks like those accounts might be commingled currently. How are we ensuring that they're separate?
Madam Chair, Stacey Weeks for the record. So the first question I'll answer myself, and then I'm probably going to give it to Lynette Aaron on my team, the second part of your question. So the independent reviewer is actually from the University of Connecticut and a subcontractor to, I think they're called Innovative Solutions. His name is written into our agreement, but he does not actually he's not an actuary. He is just more of an expert in policy, expert nationwide, and is determining for the DOJ whether or not we've met our agreement requirements. The actuary, we are currently right now, I want to say it's getting ready to go to BOE, an actuary contract with the same person who did our statewide managed care. We've been able to find some funding within our budget to be able to secure her ongoing to support our team. With a licensed actuary, but we were not budgeted for this, so we've been trying our best to make sure we have the funds. Lynette, do you want to speak to how we monitor those funds in the account?
Chair, committee members, for the record, Lynette Aaron. So while we're still working with our partners in getting those new services approved, we are working on the back end with our fiscal agent, with Gainwell, in setting up this what we call like the fiscal string, so the structure of how those services would be, in essence, charged to Medicaid or coded in our accounting system. So for new services, it is a little bit easier just because we can set up a new fiscal string. For services that we're already providing, we are working a little bit more on that as to how we can separate those payments. But we do have ways, if we can't do it through our fiscal agent system, to do it manually to ensure that we are not commingling those provider tax dollars with general fund.
Thank you. And with that, don't see any other questions. We'll go to our last one, 3160.
All right, 3160. All right, so this is another provider tax payment program, and it has been around a lot longer than our hospital program. It is our skilled nursing facility provider tax program. It was established about 20 years ago. It's in state law. It's actually a mandated tax. So unlike the hospital tax, which is voluntary and so we have to survey everyone, the skilled nursing facility fee is mandatory. So the fee is set at the highest maximum rate at 6% currently, and we collect up to 1% of that tax revenue for administrative costs. And then the revenue collected goes back out, similar to the hospital payment program, goes back out in supplemental payments to our skilled nursing facilities. Currently, this program serves about 57 facilities. In this last biennium, we paid out $215 million in supplemental payments under this tax program to skilled nursing facilities. Of these total payments, 73.7 was paid for with tax revenues collected from the skilled nursing facilities for a net gain of $141.7 million. We only have one slide for this account. So E250 is just to reflect the increased funds in the reserve. We have had a couple facilities not paying their tax balances, which puts us in a situation where we risk solvency of the account. So we're asking for a request to increase our reserve to ensure that we're able to pay out our liabilities under the program. We are working hard to start doing fees and other things that we probably haven't done in the past to enforce this program. E252 is also just funding an increase in the projected nursing facility supplemental payment. This includes any of the increases in the current program, but also includes what was passed last session, where we capture enhanced FMAP. So anytime the skilled nursing facilities serve someone who is eligible for the 90% federal funds, we're able to actually claim more in federal dollars. So this is really trying to capture that and reflect some of that funding. And I think that is it. So stand for questions.
Thank you so much. Members, any questions on this budget account? We have no questions on this one, so thank you so much, Administrator and your team, for a great job this morning. Okay, great. And so with that, we will close the budget hearings on the 7 items we heard today, and we will go to our last item on the agenda, which is public comment. If you would like to make public comment here in Carson City, please fill the tables as well if anyone here in Las Vegas, and those of us who'd like to public comment on the phone line is 888-475-4499, and the meeting ID is 893-1657-0320. Please don't forget to state and spell your name for the record, and you'll have 2 minutes when you're ready.
Chair Mosca, committee, good morning. Shelley Capro, representing the Nevada Association of Health Plans. And we're here to comment and provide comment to the budget that was proposed. And we have 4 members of our 10 that are MCOs, which are managed care organizations. Those are under the direction of the Department of Health and Human Services and through the Division of Healthcare Financing and Policy. And they serve nearly 600,000 eligible Nevadans in Clark and Washoe counties. When considering potential new Medicaid eligibility processes for Nevada families, MCOs understand the importance of infusing efficiency and clarity into processes from start to finish, and MCOs will work collaboratively and closely with the state to operationalize any selected platforms and identify processes that promote a good quality experience for member eligibility. So basically, we're here to say yes to anything that's efficient. Thank you so much.
Thank you. Seeing no others in Carson City, we will go down to Las Vegas. Yes, you may begin when you're ready.
Rebecca Ray Noah for the record. Hi.
And Miss
I'm
Rebecca, if you could
uh,
just spell your name for the record too, please. Thank you.
Sure. Rebecca Raynoha. So I'm a BCBA, so I work in behavioral health with children. And I know that in the proposed cuts that it was stated that children's behavioral health programs shouldn't be affected. I am hoping that that applies to the private sector, not just hospitals. When discussing the BA 3177, improving healthcare quality and access, one client of mine came to mind the most, which was a foster care child who engaged in self-injury, aggression, and sexualized behavior that prevented her biological parents and foster parents from wanting to maintain living arrangements with her. Because of our behavioral health services that were rendered, she is now in a foster placement moving towards adoption and potentially going into a school setting this August. Behavioral health care services are necessary for children on the autism spectrum, as well as a wide range of behavioral and developmental disorders. I just want you to consider all of our families when you're having to make these very difficult cuts. Thank you.
Thank you. Seeing no others in Las Vegas, AVH, can we please open the phone lines?
Provide public comment. Please press star 9 now to take your place in the queue. Caller, you are unmuted and may begin.
Barry Johnston, Las Vegas. I'm going to speak plainly, BerryJohnston. I'm going to speak plainly because our lives, our families, and our freedoms deserve nothing less. The Cleveland Clinic Brain Center is hemorrhaging $1 million a year. It's not sustained by excellence and innovation, but by charity. Keep hope alive isn't a slogan anymore. It's a last-ditch lifeline because administrators have failed. You parasites have stole money from the most vulnerable. You targeted people too sick, too poor, and too overwhelmed to fight back in court. Charged them with outrageous procedures that no sane country or state allows. And why? Because it looked it on social media and fed the beast of socialist propaganda. You bowed to virtue-signaling politicians, sold out real care, and drove up premiums on working-class families just to appease the online mobs and satisfy diversity quotas. You sacrificed excellence at the altar of ideology. 50% of our family doctors are gone. They're gone. The best we had. And they didn't leave quietly. They left on fire. Every single one of them told us the truth. You cut their pay. You crushed their morale. You turned world-class institutions into bureaucratic circuses. And they fled to states that actually care about our health, not headlines. Meanwhile, you let pharmacy benefit managers jack up prescription prices to absurd levels while the same medicine costs less with cash at independent pharmacies. How does that make sense? It doesn't. That's corruption, plain and simple. And now your answer, flood the system with student doctors, untested, unsupervised, experimenting on real people who killed my mom, so woke politicians can throw parades for fake progress while people suffer. This isn't healthcare. This is a clown show, propped up by taxpayer dollars and pushed by socialist PR campaigns. And I'm here to say enough. The people deserve the truth. The
Thank
people
you.
deserve
AVH,
medical
next caller,
freedom.
please.
We need the name.
There are no additional callers to provide public comment.
Thank you so much. Thank you, Director. Thank you, Administrator, for your great presentation today. And thank you to our spring breakers for going through all of that with us today. And with that, this meeting is adjourned. Thank you, members.